All right, so let's take a look at the next case. A 6-year-old boy who's presented with clumsiness and vomiting. We've got a few CT brain images here that we'll discuss in detail. First up, on the pre-contrast CT images, we can see a midline mass in the posterior fossa. This mass appears slightly hyperdense compared to the surrounding brain parenchyma, which is definitely a key feature to note. Another detail we can pick up is that this mass may contain a small area of calcification. There's also clear evidence of hydrocephalus, with dilation of both the third and lateral ventricles, which is consistent with a mass obstructing the cerebrospinal fluid pathways. When we look at the post-contrast image, there's intense contrast enhancement of the mass. This enhancement is important because it helps us narrow down our diagnosis. Let's move on to the differential diagnosis. The most likely diagnosis, based on the imaging features, is medulloblastoma. This type of tumor is very characteristic for a midline posterior fossa mass in a child, particularly with the hydrocephalus and the contrast enhancement we're seeing. However, we should still consider other possibilities in the differential. For instance, cerebellar astrocytoma is another tumor that could be considered, though it's more likely to be cystic, solid, or mixed, and could have an enhancing mural nodule, which is not what we're seeing in this case. Ependymoma could also be considered, especially since this lesion may have some calcification. Ependymomas often have both calcification and small cystic areas, but they are less common than medulloblastomas. Lastly, we have brainstem glioma. The brainstem is the most common location for this tumor, and unlike what we see here, enhancement is usually rare in brainstem gliomas. So with these considerations, medulloblastoma remains the top diagnosis. Now let's talk a bit more about medulloblastoma. Medulloblastoma is a highly malignant tumor that originates in the posterior fossa and is one of the most common primary brain tumors in children. It typically affects children between the ages of 2 to 8, and interestingly, it's more common in males. Though it primarily affects children, it can also occur in adults, but it's much less common beyond 50 years of age. This tumor arises from primitive neuroectodermal cells and is highly aggressive. It often spreads along the cerebrospinal fluid, CSF, pathways, with about 10 to 30% of patients showing evidence of this at the time of diagnosis. Medulloblastomas are also known to metastasize beyond the central nervous system to places like the bones, liver, and lymph nodes. There are some syndromes associated with medulloblastoma, like Gorlin syndrome and Turcotte syndrome. Gorlin syndrome, for example, involves basal cell carcinomas, jaw cysts, and palmar plantar pits, and can also lead to early development of medulloblastoma. Turcotte syndrome, on the other hand, is linked with familial colorectal polyposis, and these patients also have a tendency for brain tumors, including medulloblastomas. Clinically, medulloblastomas often present with clumsiness, nausea, vomiting, and signs of cerebellar dysfunction like dizziness or blurred vision. Papilloedema might be seen due to the increased intracranial pressure from the hydrocephalus, which we can clearly see in this case. As for treatment, medulloblastomas are radiosensitive, meaning radiation and surgery are the mainstays of treatment. Radiation therapy is typically combined with chemotherapy to target both the primary tumor and any potential spread along the CSF pathways. However, in younger patients, radiation can have significant side effects, such as growth restriction and cognitive impairment, so it must be used carefully, especially in patients under the age of 2 years. Now, imaging-wise, medulloblastomas have some characteristic features. They're typically located in the midline of the posterior fossa, as we see here, with a strong predilection for the cerebellar vermis. On CT, they tend to be hyperdense to the surrounding brain in about 89% of cases, helping differentiate them from tumors like pilocytic astrocytomas. Following contrast administration, they show marked enhancement, just as we've observed in this case. Calcifications may be present, though they're rare unless the patient has undergone prior radiation therapy. Subarachnoid space spread is a critical finding that may be seen on both CT and MRI, and we need to assess for this carefully. On MRI, medulloblastomas are typically low signal on T1 weighted images with varying signal intensity on T2-weighted images. They show enhancement post-contrast, and sometimes you might even see drop metastases in the spinal canal, which can be a key feature of spread along the CSF pathways. To conclude, the imaging features we've seen in this case are highly suggestive of medulloblastoma. The child should be referred urgently to a neurosurgeon for further management, including surgical resection and the consideration of radiation therapy based on the extent of the disease. I hope this case discussion has given you a good sense of how we approach a case like this, and how imaging plays a crucial role in diagnosing pediatric brain tumors like medulloblastoma. Don't forget to subscribe to Radiology Made Easy for more case discussions, and let me know your thoughts in the comments below.